Hello, I'm Dr. Zayed, one of the interventional cardiologists at Southern Mississippi Heart Center, and today we're going to talk about a very important test that has been available for the last 15 to 20 years. The test is called the calcium score or the SMART score. The calcium score is a measure of the degree of calcification present in the coronary arteries. The test is done by the use of a CT scanner. As you know, the heart is a moving object, and it moves continuously with each heart contraction, as well as with breathing, as the heart sits on the diaphragm. The availability of CAT scanners with rapid imaging capacity allowed us to take pictures of a moving object like the heart. The test is done by asking the patient to go to the CT room, abstaining from any smoking or caffeine for a few hours before the test, so as the heart rate is slow. If needed, medications could be administered to further slow the heart rate. Slowing the heart rate will prolong the period between heartbeats where the heart is still, and that allows for better images. The patient is hooked to electrodes, but there is no injection of dye or IV. The test itself is quite short. It takes anywhere from 10 to 15 minutes, and during the test, the patient will be instructed to hold his breath for anywhere from 10 to 15 seconds. During that period of time, the CT scanner will revolve around the heart and take a lot of axial images of the coronary tree, and through a computer program, the CT will reconstitute the arteries and the degree of calcium present. This test is important because, first thing, it identifies whether the patient has coronary atherosclerosis. Not only that, it also will quantify the degree of coronary atherosclerosis, but most importantly, this test is a highly predictive of the risk of future cardiovascular events like strokes and heart attacks. As a matter of fact, it's probably the most predictive test available in medicine for detecting risk of events in the future. So which patients should undergo the test? The patients that are asymptomatic, who fall in the intermediate risk category, are the ones that would benefit most from obtaining the test. Other groups that could benefit are young individuals with a strong family history of premature coronary artery disease. Also, the test could be done in any patient who is asymptomatic who has poorly controlled risk factor, like very high cholesterol or extremely high blood pressure, smoking, or diabetes. Another group of individuals that could benefit from the test are patients with chronic renal insufficiency, who tend to have a higher risk of coronary artery disease progression. Women with autoimmune disorders like rheumatoid arthritis or lupus are also good candidates for the test. So to understand why calcium score is important, we need to know a little bit about what atherosclerosis or hardening of the arteries is. We are all born with nice clean blood vessels that have no plaque buildup, but as we get older with exposure to toxins available in the environment, in addition to poorly controlled risk factors, and genetic factors, bad cholesterol, this small dense LDL cholesterol, is going to seep in the wall of the blood vessel and deposit under the lining of the blood vessel wall. This triggers an inflammatory reaction which will attract a lot of cells to the area of the lipid deposit, and a small plaque will form in the form of a streak that will gradually grow with time. As this inflammation starts healing, there is a lot of deposits of calcium in the plaque itself, and this, when it reaches a critical level, could be picked by a CAT scan, just like calcium is picked on X-rays of bone. The calcium score is reported as two numbers. One of them is the absolute score, which is called the Agatston score, after the physician who developed the test, in addition to a percentile of risk. Shown in the figures here are 4 slides of 4 patients. The first in the top left has absolutely no calcium deposits in the arteries. This patient has a calcium score of 0. The second patient has some spotty calcium that you see in the circle. This patient has mild calcium deposits. The third one has moderate calcium deposits, and the last one that you see has sheets of white calcium picked up on the CT scan. This patient has extensive calcification in the coronary arteries. The calcium score can be divided into one of 5 categories. 0, which is the lowest risk. This patient has a very low risk of having a future cardiovascular event at least in the next 5 to 10 years. The second is minimal disease, where the calcium score is between 1 and 10. Mild disease is between 10 and 100. Moderate disease is between 100 and 400, and anything over 400 is considered extensive disease. We could see calcium scores in the thousands in some patients. The second thing to be reported is the percentile of risk, and I find that to be the most alarming to the patient. Patient come in and their scan states that they fall in the 80th percentile of risk. What that means is that the patient has more calcium than 80% of the patient, his age group and sex. While this number is quite high and alarming, it does not necessarily correlate with the degree of calcification, as a young individual who falls in the 80th percentile could only have a calcium score of 20 or 30. While it means that the patient needs to pay more attention to his risk factor because of the presence of plaque, it still shows that the patient has a mild degree of plaque and there is a good chance that he can control his risk factors. How often should this test be performed? In somebody who falls in a low risk category, the test can be repeated every 7 years, while in somebody who falls in the intermediate risk category, we recommend repeating the test every 3 to 5 years. Now, some individuals, like those young patients who have a strong family history of premature coronary artery disease and are reluctant to go on medications like statins, we may elect to repeat the test more frequently, like every 1 to 2 years. The presence of new plaque on follow-up tests would be a more indication for more aggressive risk factor control, and a lot of times we will convince the patient to go on these treatments that have proven outcomes, like statins. I mentioned earlier that the test is most useful in patients who fall in the intermediate risk category. So how can you find out what your risk is? This could be very simply obtained by going on the internet and typing in the atherosclerotic cardiovascular risk score calculator. And this will give you a calculator that you will plug in your age, your sex, whether you have diabetes or no, whether you take blood pressure medications or no, whether you smoke or no, but you will need to know 2 numbers. One is your blood pressure, and the second is your cholesterol, total cholesterol, LDL, and HDL cholesterol. By plugging these numbers in and pushing the calculate button, this will tell you what your 10-year risk is. Not only will it tell you your risk, but it will also tell you what the current guidelines and recommendations are for someone who falls in your risk category. Now, for individuals who fall in the intermediate risk group, that is between the 5% and the 20%, these individuals may still be reluctant to go on statin therapy. And these are the individuals who would benefit from a calcium score. Getting a calcium score would help us calculate the risk and refine the risk assessment more by using another calculator called the MESA risk calculator, which is quite similar to the first calculator, but it takes into account the calcium score, as well as the family history, as well as the ethnic background. And they found that by using this calculator, plugging in the calcium score, you can actually change the classification from the moderate risk either to the high risk or to the low risk in 40% of the cases. So to give you an example, if somebody had an atherosclerotic cardiovascular risk of 15% and is reluctant to take statins, and we do the MESA risk calculator, if his calcium score is 0, that will shift him from the intermediate risk to the low risk, and he does not need to be on statins. On the other hand, if his risk shifts up towards the high risk group, then we have to be more forceful in recommending statins for the patient. An important question that patients ask is, how can we reverse our calcium score? And to them I say the calcium score cannot be reversed. As a matter of fact, the presence of calcification usually means that the plaque is stable. But the problem is that calcium presence is a marker of the presence of atherosclerosis. And while you have calcified plaque, you could also have non-calcified plaque. And these are likely the ones that will give you problems. Looking at the slide, we'll show you two kinds of plaque. A vulnerable plaque that has absolutely no calcium, it has a thin cap and a very rich lipid core. These are the plaques that give you problems. These are atherothrombotic plaques that tend to rupture and cause a blood clot, transforming a blockage that is not really severe into complete occlusion, giving you a heart attack or stroke. The other slide is that of a patient who has a calcified plaque. This is a more stable plaque that is less likely to rupture. And if it causes clinical problems, it's likely to cause symptoms of angina. So to conclude, the calcium score is a very valuable test indicated for screening of patients with intermediate risk or patients with strong family histories for heart disease. It is a cheap test. It runs anywhere from $75 to $150. The test entails involvement of a small exposure to radiation, no more than 1 millisievert, which is probably equivalent to the radiation exposure one gets from the atmosphere if he flies across the United States, or having a mammogram. The test is very valuable in identifying patients with coronary atherosclerosis, the degree of atherosclerosis present, and more importantly, is a very strong predictor of future cardiovascular risk. I hope you find the information that I gave you useful in combating coronary artery disease, the number one killer of American men and women in the United States. Together we can fight it, and knowledge is the most important weapon in combating heart disease. As always, stay healthy.